Welcome, everyone. I'm glad to see you all here today. Today, we'll be exploring the fascinating topic of the layers of epidermis and its histopathology. This is the first slide of our presentation, setting the stage for what's to come. We'll cover the different layers of the epidermis and delve into their histopathological features. So, let's get started and deepen our understanding of this crucial part of skin anatomy. Today, I want to highlight some fascinating facts about our skin. For a person weighing around 70 kilograms, the skin alone weighs over 5 kilograms and covers an area of nearly 2 square meters. That's quite a substantial organ. Now, when we look at the structure of the skin, it's made up of two main layers. The outermost layer is called the epidermis, which is stratified and made up of various living and dead cells. Beneath that lies the dermis, a thicker layer of connective tissue that provides strength and flexibility. These two layers are separated by a specialized basement membrane, known as the dermal-epidermal junction. Beneath the dermis, you'll find a layer of subcutaneous fat, which acts as insulation and cushioning. Interestingly, this fat layer is separated from the rest of the body by a vestigial layer of striated muscle, which is a remnant from earlier stages of development. Focusing on the epidermis, it's mainly composed of keratinocytes, which are the cells responsible for producing keratin, the protein that makes our skin tough and resilient. For the living layers of the epidermis, the thickness typically ranges from about 0.05 to 0.1 millimeters, which might seem thin, but it plays a crucial role in protecting our body. Throughout this presentation, we'll see how each of these structures and layers contribute to the overall function and health of our skin. Let's take a closer look at the layers of the epidermis, starting with the stratum basale, which is the deepest portion of the epidermis. This layer is crucial because it contains the basal cells that constantly divide and generate new skin cells. Moving upward, we reach the stratum spinosum, sometimes called the prickly layer, where these new cells start to mature and become more specialized. Next is the stratum granulosum, known for its granule-filled cells that help waterproof and protect the skin. Above that, we find the stratum lucidum, which is a thin, clear layer present only in thick skin like the palms and soles. Finally, at the very surface, we have the stratum corneum, the most superficial layer. This is composed of dead, flattened cells that form a tough, protective barrier, constantly shedding and renewing itself. Understanding these layers helps us appreciate how the skin functions as a dynamic, protective organ, constantly renewing itself to keep us safe. Let's take a closer look at the epidermis of thick skin. When we talk about the layers of the epidermis, we're really diving into the structure that provides our skin with its protective and regenerative abilities. Thick skin, like on the palms of our hands and the soles of our feet, has a particularly well-developed epidermis. Now, understanding these layers is key to appreciating how our skin functions and protects us daily. So, as we go through this slide, keep in mind how each layer contributes to the overall health and resilience of our skin, especially in areas subjected to more friction and pressure. Let's take a closer look at the stratum basale, also known as the stratum germinativum. This layer is continuous and just one cell thick, but it's incredibly important because it houses the mitotically active stem cells. These stem cells are constantly dividing to produce new keratinocytes, which are essential for the renewal of the skin. The basal cells themselves are small and cubital, with large, dark-staining nuclei that stand out under the microscope. They also have a dense cytoplasm filled with many ribosomes and tonofilaments, which are crucial for their function. In addition to these cells, you'll find membrane-bound vacuoles containing pigmented melanosomes. These originate from melanocytes and are responsible for pigmentation in the skin. Now, the basal keratinocytes attach to the basement membrane zone, or BMZ, through structural proteins like K5 and K14 at hemidesmosomes. They also connect to each other via desmosomes, which help maintain the integrity of this layer. Overall, the stratum basale is fundamental because it not only provides a continuous source of new cells, but also forms the foundation for the entire epidermis, linking cellular activity to skin regeneration and pigmentation. Let's take a closer look at the stratum basale. This is the deepest layer of the epidermis, sitting right above the dermis. It's really important because it's where the magic of skin renewal begins. The cells here are constantly dividing through mitosis, producing new keratinocytes that will eventually move upwards to form the outer layers. This process is essential for skin regeneration and healing. Another key point is that the stratum basale contains specialized cells called melanocytes. These cells produce melanin, which gives our skin its color and also provides some protection against ultraviolet radiation. Additionally, this layer includes Merkel cells, which are involved in sensory reception, helping us feel touch. Understanding the stratum basale helps us see how our skin maintains itself and adapts to environmental challenges. It's the foundation for the entire epidermis, making it crucial to overall skin health and resilience. Recognizing its role highlights how dynamic and vital our skin truly is. Now, let's take a closer look at the stratum spinosum. This layer typically contains about 8 to 10 layers of cells. These cells are polyhedral in shape, meaning they have multiple flat sides, and each contains a round nucleus at its center. If you look at these cells under the microscope, you'll notice protruding cell processes that connect neighboring cells through structures called desmosomes. These desmosomes act like cellular glue, providing strength and cohesion to the tissue. You might also notice that this layer appears spiny in stained samples. However, it's important to understand that this spiny appearance is actually an artifact caused by the staining process. When you examine unstained epidermis, this spiny look isn't present, so it's a visual effect rather than a true feature of the cells. Another key point is that the cells in this layer contain large, conspicuous bundles of keratin filaments, specifically K1 and K10. These keratin bundles are crucial because they contribute to the structural integrity and resilience of the skin, especially as it undergoes constant wear and tear. Overall, the stratum spinosum plays a vital role in maintaining the skin's strength and flexibility, connecting cells securely while beginning the process of keratinization that will eventually lead to the formation of a tough, protective outer layer. This slide doesn't contain enough information. That's why we're moving to the next slide. Let's take a closer look at the stratum granulosum. In this layer, you'll notice 2 or 3 layers of cells that contain basophilic keratohyalin granules. These granules are rich in proteins that play a crucial role in skin barrier formation. The cells and nuclei in this granular layer are actually flatter compared to those in the stratum spinosum, which indicates a progression in the differentiation process of the keratinocytes as they move upwards. Another important feature in this layer is the presence of Odland bodies, also known as lamellar bodies. These are small, subcellular structures, roughly 200 to 300 nanometers in size, and are found mainly in the upper spinous and granular layers. These bodies act as processing and storage sites for lipids, which are essential for maintaining the permeability barrier of the epidermis. Essentially, they help organize and deliver lipids that keep the skin waterproof and protect against external insults. Understanding these features highlights how the granular layer is vital for both the structural integrity and barrier function of the skin. It's a key step in the maturation of keratinocytes as they prepare to form the outermost protective layer. In this high magnification micrograph, we're focusing on the epidermis, specifically highlighting the stratum granulosum. As you can see, this layer appears more granular, which is actually where it gets its name. The cells here are starting to undergo significant changes. They're beginning the process of keratinization, which is essential for forming a tough, protective outer layer. These granules within the cells contain keratohyalin, a key component that helps in forming the skin's barrier. It's important to recognize that the stratum granulosum acts as a transition zone, moving from the living cell layers beneath to the more keratinized, dead cells of the outermost layers. This layer is crucial for skin integrity and waterproofing. Understanding this microstructure helps us appreciate how the epidermis functions as a dynamic barrier, constantly renewing itself while protecting us from environmental hazards. It's a perfect example of how microscopic changes translate into vital protective functions for the entire body. So these cells primarily exist within the stratum granulosum, which is a critical layer of the epidermis. Here, they play a key role in promoting the formation of the epidermal cornified cell envelope, a structure also known as cornification or keratinization. This process is essential for creating a tough, protective barrier on our skin's surface. A central component in this process is profilagrin, which is a large precursor protein, over 400 kilodaltons, that eventually gets processed into filigrin. Filigrin is the main constituent of the keratohyalin granules, or KHG for short. These granules are essentially the storage sites for profilagrin and other proteins that help in forming the skin's outermost protective layer. Understanding how profilagrin and keratohyalin granules work together is fundamental to grasping how our skin develops its barrier function. This process is not only fascinating, but also vital for maintaining healthy, resilient skin. Let's take a closer look at how filigrin contributes to skin health. When filigrin breaks down, it releases hygroscopic free amino acids and their derivatives, such as pyrrolidone carboxylic acid, or PCA. This process is a major part of the natural moisturizing factor, or NMF, produced within the outermost layer of our skin, the stratum corneum. Now, the NMF plays a crucial role in maintaining skin hydration, especially in low humidity environments, helping our skin retain water and stay supple. Another important derivative of filigrin degradation is transuricanic acid, or UCA. This compound is generated from free histidine, an amino acid abundant in filigrin, through the action of an enzyme called histidase. Essentially, since filigrin is rich in histidine, its breakdown provides a significant source of UCA in the epidermis. Trans-UCA isn't just a passive byproduct. It can be converted by ultraviolet B radiation into cis-UCA. Interestingly, cis-UCA has been shown to be a key player in UVB-induced immunosuppression. This means it can influence how our immune system responds to UV exposure, which is a fascinating link between skin chemistry and immune regulation. Now, shifting gears a bit, mutations in the gene FLG, which encodes profilagrin and filigrin, have significant implications. These loss-of-function mutations are a common cause of ichthyosis vulgaris, a condition characterized by dry, scaly skin. What's more, these mutations are quite prevalent. They're carried by up to 10% of people, and they also increase the risk for atopic eczema, asthma, and allergies. So, understanding filigrin's role helps us see why genetic factors can predispose individuals to various skin and allergic conditions. Let's take a closer look at Odland bodies, also known as lamellar bodies. These are ovoid-shaped structures, roughly 200 to 300 nanometers in size, and they serve as secretory organelles with a double membrane. You'll mainly find them in keratinizing cells, especially the keratinocytes located in the upper spinous layers and in the stratum granulosum. Odland bodies are packed with important lipids like phospholipids, glucosylceramides, sphingomyelin, and cholesterol. They also contain a variety of enzymes, including lipid hydrolysases such as beta-glucose rebrosidase and acidic sphingomyelinase, as well as secretory phospholipase A2, neutral lipases, and proteases like kallikreins and cathepsins. These lipids stored in the Odland bodies are actually the precursors of the extracellular lipids in the stratum corneum, which is crucial for maintaining the skin's barrier. The formation and secretion of these lipids are vital for permeability barrier homeostasis, meaning they help keep the skin's barrier functioning properly. Research has shown that a protein called ABCA12, which is part of the ABC transporter family, is essential for forming Odland bodies. If there are mutations in ABCA12, the formation of these bodies is disrupted, and the extracellular lipid membranes don't develop correctly. This highlights just how critical proper lipid transport and Odland body formation are for healthy skin function and barrier integrity. Disorders associated with abnormalities of Odland bodies are quite significant because these structures play a crucial role in skin barrier formation and overall epidermal health. When Odland bodies, also known as lamellar bodies, don't develop or function properly, it can lead to a variety of skin conditions. These abnormalities can manifest as issues with skin hydration, increased sensitivity, or even more severe disorders. For example, some inherited ichthyoses are linked to defects in the formation or secretion of Odland bodies, resulting in dry, scaly skin. Recognizing these connections helps us understand the importance of Odland bodies in maintaining healthy skin. So, in essence, any disruption in their normal development can have wide-ranging effects on skin integrity and function, tying directly into our broader discussion of skin barrier health and disease. The stratum lucidum is a smooth, seemingly translucent layer of the epidermis that sits just above the stratum granulosum and below the stratum corneum. This layer is quite thin and is composed of dead, flattened keratinocytes. What's interesting is that this layer is only found in thick skin, such as on the palms, soles, and digits, areas that need extra protection and durability. The cells in the stratum lucidum are densely packed with a clear protein called eladin, which is rich in lipids and derived from keratohyalin. This composition gives the layer its transparent, or lucid, appearance. Additionally, eladin forms a barrier to water, helping to prevent dehydration of the skin. Overall, the stratum lucidum plays a crucial role in the skin's protective barrier, especially in those thicker skin areas designed to withstand friction and pressure. The stratum corneum is the most superficial layer of the epidermis, and it's the part that's directly exposed to the outside environment. This layer has undergone increased keratinization, also called cornification, which is what gives it its name. Essentially, the cells here have become tough and resilient. This layer is composed of about 15 to 30 layers of what we call corneocytes, which are actually the largest cells in the epidermis. These cells are flattened and have lost their nuclei and other cytoplasmic organelles, a process that makes them more specialized for their protective role. They mainly retain keratin filaments, which are embedded in a matrix of filaggrin. Now, the stratum corneum isn't just a random collection of dead cells. It's made up of a network of these corneocytes and an extracellular lipid matrix. Think of it as a two-compartment system. The hydrophobic, protein-rich corneocytes are sequestered within a lipid-enriched matrix. This organization is often described as a bricks and mortar structure, where the corneocytes are the bricks and the lipids act as the mortar, forming lamellar membranes that are crucial for barrier function. Within this layer, you can see different patterns, an upper basket weave pattern and a lower, more compact layer, each contributing to the overall flexibility and protective qualities of the skin. So, in essence, the stratum corneum is our first line of defense, structured in a way that provides both a physical barrier and controls what passes in and out of our body. It's a fascinating example of how form and function come together at the cellular level to protect us daily. This slide doesn't contain enough information. That's why we're moving to the next slide. In this slide, we're looking at hyperkeratosis, which is essentially an abnormal thickening of the outermost layer of the skin, the stratum corneum. Now, there are two main types to keep in mind. First is orthokeratotic hyperkeratosis, where the keratin layer becomes thickened, but the keratinocytes still mature normally, meaning their nuclei are gone as they should be. On the other hand, perikeratotic hyperkeratosis involves retained nuclei within the keratin layer, indicating a delay or abnormality in keratinocyte maturation. Most often, this thickening results from chronic physical or chemical damage. Think of repeated friction or harsh soaps. But it can also stem from chronic inflammation or even as a side effect of certain medications, including chemotherapy. Genetic factors play a role too. Mutations that cause hyperkeratosis are seen in conditions like ichthyoses and keratoderma, which are inherited disorders characterized by abnormal keratinization. Another important point is nutritional deficiency, especially vitamin A deficiency, which can lead to a condition called phrinoderma, characterized by hyperkeratotic skin lesions. So, as you see, hyperkeratosis isn't just a simple thickening. It's a sign of various underlying processes, whether due to environmental damage, genetics, or nutrition, all of which tie into the broader theme of skin health and disease. Let's talk about hyperkeratosis. This condition involves an abnormal thickening of the outer layer of the skin, specifically the stratum corneum. It's often a response to persistent friction, pressure, or irritation, which causes the skin to produce more keratin as a protective mechanism. You'll notice this as rough, thickened patches on the skin, sometimes with a calloused appearance. Hyperkeratosis is important to recognize because it can be a sign of underlying chronic trauma or other dermatological issues. In the context of our overall discussion, understanding hyperkeratosis helps us appreciate how the skin reacts and adapts to various stimuli, sometimes in ways that may require medical attention if they become problematic. Today, I want to talk about perikeratosis, which refers to the retention of nuclei within the cells of the stratum corneum. Normally, these outermost skin cells lose their nuclei as they mature, but in perikeratosis, you see nuclei still present, indicating abnormal keratinization. Perikeratosis can appear in different patterns within the stratum corneum, and recognizing these can help us identify various skin conditions. One common form is broad or confluent perikeratosis, where it covers most of the surface area of a punch biopsy. This pattern is typical in diseases like psoriasis, pityriasis rubra pilaris, and Bowen's disease. Interestingly, in pityriasis rubra pilaris, the perikeratotic cells are arranged in an orderly, alternating pattern with orthokeratotic cells, creating a sort of chessboard appearance. Another pattern is elongated mounds, which you might see in large plaque parapsoriases and occasionally in pityriasis lichenoides chronica. Then there are small mounds of perikeratosis, seen in conditions like pityriasis rosea, pityriasis lichenoides chronica, eruptive psoriasis, especially when neutrophils are involved, seborrheic dermatitis, particularly around hair follicles, and subacute spongiotic dermatitis where plasma cells are present. Finally, perikeratosis can alternate with orthokeratosis, and this pattern is observed in various disorders including psoriasis, pityriasis rubra pilaris, solar keratosis, and verruca vulgaris. Overall, recognizing these different patterns of perikeratosis helps us differentiate between various dermatological conditions and understand their underlying pathology better. Let's take a closer look at the structure of the stratum corneum. What's interesting here is that it has an alternating pattern of ortho and para arrangements. These are organized both from top to bottom and from left to right within the layer. This alternating pattern is crucial because it influences the barrier properties and flexibility of the skin. Recognizing these structural details helps us understand how the skin provides such effective protection while remaining adaptable. So, in essence, this pattern is a fundamental aspect of the skin's architecture, tying back to our overall discussion on skin function and health. Let's take a closer look at columnar perikeratosis. When perikeratotic cells are arranged in a vertical column, they can form different distinct patterns. One common pattern is when these columns alternate with orthokeratotic columns, which we see in conditions like verruca vulgaris and solar keratosis. This alternating pattern is quite characteristic and helps in diagnosis. Another interesting pattern is called the cornoid lamella. Here, a perikeratotic column overlays a small vertical zone of diskeratotic and vacuolated cells within the epidermis. This pattern is a hallmark of porokeratosis and is important to recognize. We also observe what's called stubby perikeratosis. In this case, the broader perikeratotic columns alternate with larger zones of orthokeratosis. This pattern is typical in inflammatory linear verrucous epidermal nevus. Understanding these patterns is key because they help us connect microscopic features to specific clinical diagnoses, which ties into the overall theme of recognizing epidermal changes in different skin conditions. Let's take a closer look at the cornoid lamella. This is a key structural feature that plays a crucial role in certain skin conditions. Essentially, the cornoid lamella appears as a thin, vertical column of abnormal keratinocytes that extends through the stratum corneum. It's like a distinct plug or column that stands out under the microscope. Recognizing this feature is important because it helps us confirm the diagnosis of conditions like porokeratosis. The presence of a cornate lamella indicates a localized clone of abnormal keratinocyte proliferation, which is a hallmark in these disorders. So, when we're evaluating skin lesions, spotting the cornate lamella can be a vital clue, connecting the microscopic findings to the clinical picture we've been discussing in this presentation. Diskeratosis occurs when some keratinocytes keratinize abnormally before they even reach the stratum corneum. You can see that the affected keratinocytes show an intense eosinophilic, or dark pink, staining of abnormal keratin material within their cytoplasm. This abnormal keratinization leads these cells to become apoptotic and necrotic, meaning they start to die off. As they do, their nuclei shrink and contain eosinophilic cytoplasm, which is a key feature to recognize. Since the intercellular bridges between the peripheral keratinocytes are lost, these cells become round in shape. Diskeratosis is quite common and is often associated with inflammatory diseases and malignant tumors. For example, in Derrier's disease, diskeratosis appears as grains in the stratum corneum, whereas in Bowen's disease, it manifests as individual cell keratinization. Understanding diskeratosis is important because it highlights abnormal keratinocyte behavior that can be linked to various skin conditions and tumors. It's a sign of abnormal differentiation and is a crucial concept as we explore skin pathology overall. This slide doesn't contain enough information. That's why we're moving to the next slide. Hypergranulosis is characterized by a thickening of the granular cell layers in the skin. Normally, we see 1 to 3 layers of these granular cells, but in this condition, it expands to 4 or more layers. This change is significant because it reflects an abnormal response or adaptation within the skin tissue. You'll often find hypergranulosis in conditions like lichen planus, viral warts, and even congenital ichthyosis. These are quite different conditions, but they all share this particular histological feature. Now, an interesting point is that in lichen planus, hypergranulosis often takes on a wedge-shaped appearance. This specific pattern can be a helpful diagnostic clue for pathologists when they examine tissue samples. So, in the context of our overall discussion on skin pathology, hypergranulosis highlights how the skin responds structurally to various stimuli or disease processes. Recognizing these patterns helps us understand the underlying pathology and guides appropriate treatment strategies. Let's take a closer look at wedge-shaped hypergranulosis. This term refers to a specific histopathological feature where we see an area of thickened granular layer that takes on a wedge or triangular shape. It's quite characteristic and can be a key diagnostic clue. The hypergranulosis indicates an increased granular layer, often in response to chronic irritation or inflammation. When this thickening has a wedge shape, it usually points to a localized pattern, helping us distinguish certain conditions from others. Recognizing this feature is important because it connects to the overall theme of how tissue responds to various stimuli, be it mechanical, chemical, or biological. So, understanding wedge-shaped hypergranulosis helps us piece together the bigger picture of tissue adaptation and pathology. Now, on this slide, we're looking at the thickening of the epidermis and the elongation of the reedy ridges, which occurs due to the thickening of the spinous layer. This is a key feature seen in chronic eczematous reactions. Essentially, when the skin has been inflamed or irritated over a long period, these structural changes happen. The term for this process is acanthosis, which refers to the increased thickness of the epidermis. This thickening and elongation of the reedy ridges help us understand the skin's adaptive response to ongoing inflammation. Recognizing acanthosis is important because it indicates a chronic process and can help differentiate between different dermatological conditions. It's a classic histopathological feature that ties into the overall theme of how chronic skin inflammation induces structural changes in the skin layers. Acanthosis is a term that refers to the thickening of the skin, specifically in the stratum spinosum layer. It often appears as darker, velvety patches particularly in areas where the skin folds, like the neck or armpits. This thickening results from hyperplasia of the epidermis, which is usually a response to chronic irritation or hormonal influences. In the context of our overall discussion on dermatological signs, acanthosis is particularly significant because it can be a marker for underlying conditions, such as insulin resistance or metabolic syndrome. Recognizing these skin changes can help in early diagnosis and management of systemic diseases. So, when you see acanthosis, think beyond just the skin. Consider the broader clinical picture and what it might indicate about the patient's health overall. It's a great example of how dermatology often mirrors internal health issues. Let's talk about spongiosis, which is a key feature we see in certain skin conditions. It occurs when the spaces between neighboring keratinocytes, the main cells in the outer layer of the skin, become enlarged due to intense edema. Essentially, this means that fluid builds up and causes these gaps to widen. As a result, the intercellular space becomes more extended and distinctly noticeable under the microscope. This process is commonly found in eczemas and dermatitis, including conditions like contact dermatitis, atopic dermatitis, and acute eczema. Recognizing spongiosis is important because it helps us differentiate between different inflammatory skin diseases and understand their underlying mechanisms. So, in essence, spongiosis reflects an inflammatory response that leads to fluid accumulation and separation of keratinocytes, contributing to the clinical appearance of these dermatitis conditions. It ties into the broader theme of skin inflammation and how cellular changes manifest visibly in skin diseases. Let's talk about spongiosis, which is a key concept in understanding certain skin conditions. Spongiosis refers to the intercellular edema within the epidermis, meaning fluid buildup between the keratinocytes. This fluid accumulation causes the cells to become slightly separated, creating a sponge-like appearance under the microscope. It's most commonly seen in inflammatory skin diseases, especially eczematous dermatitis. Recognizing spongiosis is important because it helps differentiate eczema from other skin disorders. Essentially, it highlights the inflammatory process occurring in the skin, which ties back to our overall theme of understanding skin pathology and immune responses. So, in summary, spongiosis is a hallmark of many inflammatory skin conditions and provides valuable clues about the underlying pathology. Acantholysis is essentially the breakdown or dispersion of keratinocytes, which are the primary cells in the epidermis. This happens because the intercellular adhesion between these cells, especially in the desmosomes, gets disrupted. When this adhesion fails, intercellular spaces open up, and blisters can form as a result. Within these blisters, you'll see acantholytic cells. These are spherical keratinocytes that have lost their connections to neighboring cells and are now floating freely inside the blister. An important point to remember is that these acantholytic cells tend to become dyskeratotic, meaning they start to show abnormal keratinization, which is often seen in certain skin diseases. This phenomenon, acantholysis, is characteristic of several conditions, including pemphigus, Hailey-Hailey disease, and Darier's disease. Understanding acantholysis helps us grasp the underlying mechanisms of these blistering and dyskeratotic disorders, which is central to our overall exploration of skin pathology. This slide doesn't contain enough information. That's why we're moving to the next slide. Let's take a closer look at the collection of leukocytes within a skin section. Usually, these are neutrophils, but their specific location and cell type help us categorize them into different types. First, we have the papillary tip microabscess, which is a collection of neutrophils at the tips of the dermal papillae. This feature is often seen in dermatitis herpetiformis. Next is Monro's microabscess, characterized by a collection of neutrophils, many of which are pinotic, located within the stratum corneum. This is a classic finding in psoriasis. Then, we see microabscesses at the center of a granuloma. These are collections of neutrophils within granulomas, indicating suppurative granulomatous inflammation. Such microabscesses suggest infectious causes like mycetoma or botryomycosis. We also have intraepidermal eosinophilic abscesses, which are collections of eosinophils within the hyperplastic epidermis, typically seen in pemphigus vegetans. Finally, Potrier's microabscesses are collections of lymphocytes surrounded by a halo within the epidermis, notably without spongiosis. These are characteristic of mycosis fungoids. Understanding these different types helps us identify the underlying pathology and guides diagnosis and treatment. Now, let's take a closer look at Monro's microabscess. This is a small, pinpoint collection of neutrophils that forms within the epidermis. It's often seen in conditions like psoriasis, where you have this rapid turnover of skin cells. The key point here is that these microabscesses are essentially tiny pockets of inflammatory cells that accumulate due to the immune response. They serve as an important histological feature because their presence helps us identify and confirm certain dermatological diagnoses. Connecting this to the overall theme, understanding these microabscesses enhances our grasp of the inflammatory processes underlying various skin conditions. Recognizing Monro's microabscesses can really aid in distinguishing between different dermatoses, making it a vital concept in dermatopathology. Let's take a closer look at some of the key cellular components found in the epidermis. First, we have melanocytes. These cells are responsible for producing melanin, the pigment that gives our skin its color and also provides some protection against ultraviolet radiation. Next, there are Langerhans cells, which play a crucial role in our immune response by acting as antigen-presenting cells. They help detect and fight off pathogens that may invade the skin. Moving on, we have Merkel cells, which are involved in sensing touch and pressure, contributing to our tactile perception. Lastly, we should remember that the epidermis isn't just made up of keratinocytes. There are also non-keratinocyte cells like the ones we've discussed, each playing a vital role in maintaining skin health and function. Understanding these diverse cell types highlights the complexity and sophistication of our skin as a protective and sensory organ. Let's talk about dendritic cells derived from the neural crest, which are present in the basal layer of the epidermis. When we look at melanocytes under the light microscope, they appear with a pale staining cytoplasm, an ovoid nucleus, and contain pigment-filled melanosomes. These melanosomes are responsible for pigment production and distribution. Melanocytes establish contact with keratinocytes through their cellular processes, but importantly, they do not form junctions with them at any level. This means they communicate and transfer pigment without direct cell-to-cell junctions. Typically, one melanocyte interacts with about 36 basal and suprabasal keratinocytes, forming what we call an epidermal melanin unit. It's also interesting to note that the number of melanocytes per unit area of skin varies across different parts of the body. But when comparing different races, the density of melanocytes remains quite consistent. The racial differences in skin color are actually due to variations in the distribution and size of melanosomes within keratinocytes, not the number of melanocytes themselves. Understanding these points helps us see how pigmentation is regulated at a cellular level, which is essential for appreciating the complexity of skin color and its variations. In vitiligo, what happens is that the melanocytes, which are the cells responsible for producing pigment, are actually destroyed. This leads to those characteristic depigmented patches we see. In contrast, in albinism, the number of melanocytes remains normal, so the cells are still there, but they can't fully produce pigmentation. This is because of a defect in the enzymes needed to make melanin, which results in very light or even white skin and hair. Now, moving on to freckles, these are a bit different. Freckles occur when a normal number of melanocytes produce more pigment in certain localized areas, leading to those small, pigmented spots. Then we have lentigines, which are actually a form of melanocytic hyperplasia, meaning an increase in the number of melanocytes, resulting in darker patches that are more pronounced than freckles. Finally, nevi, or moles, are benign proliferations of melanocytes. They're generally harmless but are important to recognize as they are common pigmented lesions. All of these variations highlight the different ways melanocytes and melanin production can change, either in number or function, and how these changes contribute to the diverse pigmentation patterns we observe. Let's take a moment to differentiate between freckles and lentigines, as they are often confused but actually quite distinct. Freckles are small, flat, brownish spots that usually appear in people with lighter skin, and they tend to become more prominent with sun exposure. They are often genetic and tend to fade in the winter months. On the other hand, lentigines, sometimes called age spots or liver spots, are also flat and pigmented, but they are generally larger, darker, and more well-defined. They tend to appear with aging and sun damage, and unlike freckles, they don't fade over time. Understanding these differences is important because it influences how we approach treatment and prevention. Freckles are more about genetic predisposition and sun exposure, whereas lentigines are more about cumulative sun damage over the years. Both types of pigmentation are part of the skin's response to UV exposure, but recognizing which is which helps us tailor our skincare and treatment strategies effectively. This distinction also ties back to our overall theme of understanding skin aging and pigmentation changes. Now, here we have a magnified view of the lentigines, showing us the melanocytic hyperplasia at about 200 times magnification. What's important to note here is that this hyperplasia means there's an increased number of melanocytes in the lesion. This feature is quite characteristic and helps distinguish lentigines from common freckles. In freckles, the number of melanocytes remains normal. What changes is the amount of melanin produced by those cells. In contrast, in lentigines, there's an actual increase in the melanocyte count, which contributes to the distinct appearance and behavior of these lesions. Understanding this difference is key in dermatopathology because it guides us in diagnosis and management. Recognizing the hyperplasia helps us differentiate lentigines from other pigmented lesions, especially those that are simply due to increased melanin production rather than cell proliferation. So, in summary, this slide emphasizes that the characteristic feature of lentigines at the cellular level is melanocytic hyperplasia, setting them apart from freckles, which have normal melanocyte numbers but increased melanin. Langerhans cells are quite interesting because they resemble melanocytes in some ways, but there are key differences. For example, they are dopa-negative, meaning they don't produce melanin, but they are at PACE positive, which helps us identify them through specific staining techniques. These cells originate from the bone marrow, highlighting their role as part of the immune system, rather than being derived locally in the skin. They are distributed throughout the different layers of the epidermis, specifically in the basal, spinous, and granular layers, which shows how integrated they are in skin immunity. Interestingly, they make up about 2 to 8% of the total epidermal cell population, so they're not the most numerous, but their function is crucial. Another key point is that these cells don't form junctions with the cells they are near, which is different from many other skin cells. Under electron microscopy, Langerhans cells have distinctive rod or racket-shaped granules, known as Burbeck granules, which are quite characteristic and help in their identification. Speaking of identification, CD1 immunolabeling is considered the most reliable method for identifying these cells in humans. This technique allows us to specifically stain and recognize Langerhans cells among other epidermal cells. Now, why are Langerhans cells so important? They play a vital role in skin immunity. They are heavily involved in presenting antigens, basically showing foreign particles to the immune system, thus stimulating T-cell responses. They also perform phagocytosis, which means they can engulf and digest pathogens or debris, helping to protect our skin from infections. So overall, Langerhans cells serve as a crucial first line of defense in our skin, acting as immune sentinels that detect, process, and present antigens to activate other immune cells. Their unique features and strategic location make them indispensable for maintaining skin health and immune surveillance. Let's talk about Merkel cells. These are slow-adapting, type I mechanoreceptors, which means they respond to sustained touch stimuli. They are located in areas of high tactile sensitivity, so places like our fingertips, lips, and certain parts of the oral cavity. Interestingly, they originate from epithelial cells, which is quite unique for sensory receptors. Merkel cells are found in both hairy skin and glabrous skin, such as the pads of the fingers and lips. When you look at them under a microscope, you'll notice they have a pale staining cytoplasm, making them distinguishable. Their nuclei are lobulated, giving them a distinctive appearance, and their cell margins project cytoplasmic spines towards nearby keratinocytes, which helps facilitate communication. These cells are embedded in the basal layer of the epidermis and form desmosomal connections with surrounding basal keratinocytes. These connections are crucial because they help maintain the structural integrity and facilitate the sensory functions of Merkel cells. Overall, Merkel cells play a key role in our tactile perception, especially in detecting fine details and sustained pressure, which ties back into the overall theme of how our skin and sensory system work together to provide detailed touch information. Thank you so much for your attention and engagement throughout this presentation. I truly appreciate your time and interest. If you take away just one thing from today, I hope it's the importance of applying these insights to make meaningful progress in your work. Remember, the key points we've discussed, whether it's innovation, collaboration, or strategic thinking, are all interconnected and vital to success. I encourage you to carry these ideas forward and continue exploring how they can shape your future initiatives. Again, thank you for being such an attentive audience. I look forward to seeing how you put these concepts into action.